All right.
All right, go ahead.
Okay. Okay. Thank you. Harvey Abernathy is our technical host today. He's in the background at all times. So, good morning. I'm Gary Gonzer, the president of ESCOM, and I wanted to welcome you to this Spotlight talk on family caregiving. Today we have Dr. Jennifer Olsen, CEO of the Rosalynn Carter Institute for Caregivers, with us. Dr. Olsen is coming to us from Plains, Georgia, with the help of Zoom and our internet. This will be the first program with a speaker from out of state. So it's interesting. We have some 18 people online this morning, and I wanted to put in a plug for ESCOM just for a second, just to remind people that it's easy to join ESCOM for free and enjoy all of its benefits, including notices of future spotlights and events and local computer training. Just go to our website at www.escom.marin.edu and select the join link on the left side of the screen. Caregiving is critical for our world. 105 million Americans currently serve as family caregivers to someone who is aging, ill, or disabled. This does not count those who are receiving the needed care. Dr. Jennifer Olsen has been working from the Rosalynn Carter Institute for Caregivers from its inception 6 years ago. The Institute was started by First Lady Rosalynn Carter to support this important work on a national level. On a personal note, Rosalynn Carter passed away almost exactly 1 year ago on November 19, 2023. Her continuing work to support older people in all caregiving situations was tireless and heartfelt, and we all remember her for her amazing lifelong service to us all. One note that Mrs. Carter made everywhere she went is there are only four kinds of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. With that, I want to warmly welcome Dr. Jennifer Olsen. It is an honor to have you with us this morning. Thank you.
Thank you, Gary, and I'm delighted to be with the ESCOM community. Good morning to all of you, and I hope that those who are watching in the recording will enjoy this talk as well. I'm hopeful also that today can be a mix of presentation and conversation. I'll walk through some slides and some information about the current state of caregiving, including some pro tips for those who are in the throes of caregiving right now. And then I'm hopeful that we'll have some robust discussion at the end of our time together. As Gary noted, this is a unique time of year for us as we get ready to mark the 1 year of anniversary of Mrs. Carter's passing. I'm based in Plains, Georgia, a small town of 700 in rural Georgia, but we know that Mrs. Carter's impact reached not just all of our communities here in Plains, but across the world. And so we recognize and honor that lifetime of service, but realize there is much work to continue. As you heard, 105 million family caregivers across the country. So I'm going to, as I said, share some slides, walk through some information, give you hopefully some new and different things to think about while we've heard a lot about caregiving more and more so, especially over the past few years. I'm hopeful that today we can discuss some of the emerging issues and opportunities in the caregiving landscape, as well as to recognize that both policy and politics impact the support of family caregivers across the country and in states and communities. With that, I'm going to share some slides about this part. All right. So as I said, I'm going to walk through the organization just to give you a bit of history of the work that we do so that you kind of know where I'm coming from, the organization comes from, talk about the caregiver landscape of today, discuss some ways that we see opportunities for change and improvement for supporting family caregivers in the current landscape. Now, I recognize the politics of the past few weeks have some impact on our understanding of what opportunities may exist for supporting caregivers at the federal level, but I'm going to talk about some overarching issues and some new regulations so that you're all up to date on what's going on in that space. And then I'll close with very practical pro tips. Gary already kindly used Mrs. Carter's quote, but I like to remind us all that Mrs. Carter's caregiver journey started when she was 12 years old, so almost 80 years of understanding, over 80 years of understanding the caregiver experience. Her father was diagnosed with leukemia when she was very young, and she saw the impact that this had on her mother, having to balance caregiving for a spouse while also supporting young children, maintaining a job, and trying to hold so many things together for her family, even with the support of local community. Then, as Mrs. Carter's journey through the governor's mansion and the White House continued, she continued to talk to people who shared their caregiver story. This also often came up from her work with mental health, an area that she spent a significant portion of her White House time focused on. And she realized that for everyone with a mental health condition, there was often a caregiver or more than one caregiver who was part of keeping that individual healthy and well, but that caregiver was often invisible. And so in 1987, she started the Rosalynn Carter Institute for Caregiving, based at Georgia Southwestern State University, a small state university here in Georgia. And that work initially was focused on caregivers of those with mental health conditions. She then expanded quickly to supporting caregivers of those with cancer, caregivers of those with dementia, and caregivers of veterans. And so as we mark almost 40 years, Gary mentioned 6 years ago, we changed our name and transitioned our organization to be outside of a university setting so that we could more actively engage in policy advocacy, because no one other than our founder understood the power of the White House in supporting change. And so we continue this work today. Our institute right now, based on guidance from Mrs. Carter over time, is focused on changing and supporting the health, strength, and resilience of family caregivers. And so we do this through research, through engagement with the private sector community, so some of the newer health systems or health technologies that support caregivers, and some non-traditional partners, including Sesame Street and FEMA, and I'll talk about some of that later. We envision a world where every caregiver is seen and supported, and look forward to ways to continue this work in settings both locally in our Georgia backyard and across the country. And so I just want to ground you a little bit about how we think about supporting caregivers. I mentioned that we changed our organization name and our focus about 6 years ago with the intention of suggesting the idea that while we could be an organization that supports people in the activities of caregiving, which I'll talk about in a moment, you know, anything from changing bandages to IV lines, we wanted to support and center our work on caregivers, the individuals who are doing that work. There are shifting demographics and an increased number of caregivers, which I'll talk about, and that we have an opportunity across all of our work to think more about early intervention and prevention, so that we're supporting caregivers early and often. And we do this because we realize that most of the time when somebody reaches out to a caregiver organization, and this may or may not be some of you on this call, it's when you're in a point of crisis or challenge. It's the 11th hour. Most of our hits to our website happen between 2 a.m. and 4 a.m. Across the time zones of the country, when people are in their most challenging state. And while we look for ways to continue to support individuals in those challenging times, we know that our best opportunity is to find ways to support caregivers, as I said, early and often. I'll just put this idea out there. When you go to the doctor's office, have they ever asked if you're caring for anyone? I'll explain later why that matters, but I'm going to guess that that has rarely or never happened. And so, as I said, I'm going to talk a bit about today's family caregiver, get you steeped in kind of what the state of the numbers are and the impacts of caregiving, so that you can have an idea of the work that we intend to and continue to do. And I hope that some of you will see your own experiences reflected in some of these insights. So this talk is beautifully named Caregiving in the 21st Century, because caregiving has indeed changed. Yes, there are some constants. You know, when Mrs. Carter started her caregiving journey 80 plus years ago, she was experiencing some of the challenges and hardships that people experience today. But we also know that there have been shifts, demographic shifts, increased aging population, the beauty and wonder of science and technology, enabling people longer lifespans or ability to continue to thrive, even with conditions that were previously life-limiting. We also know that there's been decreases in birth rates, so that impacts family dynamics about who will care for individuals and what that will look like, as well as changes to family structure. I can share some stories of caregivers who are caring for someone that they're divorced from, caregivers caring for extended family, neighbors, former bosses. I've heard every constellation of what family caregiver could look like, and I think that will only continue to evolve. Distance caregivers, family members who live a few states or countries away from the person they're caring for, who are trying to figure out that dynamic of how to be supportive. Our veteran caregiver landscape post 9/11, transitioning from what were primarily physical health conditions to a mix of physical and mental health challenges. And as I said, advancements and the wonder of medical science. All of that has changed the caregiver landscape. And in the pre-COVID times, our estimate in the country was that there were 53 million family caregivers. The caregivers were averaging age between 50 and 64, that they were often caring for a spouse or a parent, and some of those trends continue today, and that there was a slight increase in women, or a number of women who are caring for individuals as compared to men, continuing a belief that this caregiving is women's work. The impact, though, is not just that someone is a caregiver, but rather that caregiving impacts physical, mental, and financial health. People report that over a quarter of family caregivers report that their physical health has been challenged, that they have missed medical appointments, that they have skipped paying for their own medications in place of supporting the person they're caring for, that sleep deprivation, isolation, and stress are all at increased levels for caregivers as compared to non-caregivers. Substance use and abuse issues are increased for family caregivers. And all of, not to mention kind of what you might think of as more physical impacts, back strains, broken bones, and other challenges from the physical labor of being in a family caregiver role. So we recognize in our work that family caregivers, today's family caregiver, is tomorrow's patient if we don't do more to thoughtfully consider the work and the role that these individuals hold. And I mentioned the financial burden. This comes from supporting out-of-pocket medical expenses, reducing work hours or leaving the workforce altogether, reducing time in the workforce, which impacts retirement savings. There's a number of financial impacts that family caregiving has. Very few are fully understood because caregiving is something for which we don't study in a longitudinal fashion, but there's work underway to do that. And I mentioned broadly these physical and mental health impacts. These are not just, as I said, missed appointments or increased diagnoses. These are the ways in which family caregivers themselves have felt that their role impacted their well-being and how that has continued to increase. But COVID changed many things, and one of the things that it changed is our approach to estimating family caregivers. And as was mentioned, the new estimate of family caregivers in this country is 105 million individuals, adults, are caring for friend, family, or neighbor. That's 40% of US adults in this role. And yet I would contend that we rarely hear about this population and this community and the health impacts in the way we might hear about other issues. This slide shows that difference in the military and the civilian caregiver community, just to give you an idea of kind of what that looks like. The reason that this was done this way is that RAND has received support for studying veteran caregivers, and this time they increased their purview to include the civilian caregiver community, and have continued, and you'll see in the work that they did to break down caregivers, as the next slide shows, where the care recipient is under 60 and over 60, to look for where those impacts might be, again, from that veteran lens of thinking about caregivers who are often post 9/11, what supports and differences exist. But the reason I show this is to help us to understand that I think there's a lot of perceptions about caregiving being that spouse or that partner, but yet there are a number of constellations of caregiver experience across the board, and they evolve as both the care recipient ages and the caregiver ages, including us for the first time experiencing and supporting more and more caregivers who are in their 60s and 70s caring for parents in their 80s and 90s, and that was not in our traditional approach to caregiver support. And so in some ways, age breakdowns like this are soon to be obsolete. The other thing I mentioned is this idea of caregiver stress. So these are the latest numbers on the perceived stress and depression for caregivers as compared to non-caregivers. Significantly different and not surprising. These are post-COVID numbers. So after the pandemic, the differences still exist. They were true before the pandemic, exacerbated during, and continue after. And so again, thinking about this as a population, and if you've been yourself in a caregiver role where those stresses and burdens are increased, and we know that those don't just have mental health impacts, but physical as well. And you've heard me kind of reference these big numbers. You see that 53 on the edge of this slide, these 53 million family caregivers, the 105 that RAND just reported last month. And yet I would contend that if you listen to the nightly news, if you listen to nightly news anymore, like I still do, that the conversations are often about a number of other health conditions and opportunities. And family caregiver health issues are not seeing as much screen time. But I'm optimistic. So now I'm going to talk a bit about what those opportunities are. That I think are possible for supporting and changing the supports for family caregivers across the board. And one of those is belief in ongoing work to research and understand the caregiver community. I mentioned that idea of if you've ever been asked at the doctor's office if you're a caregiver. I think there's some question about if this is such a big part of our population, how come we still don't fully understand it in the way that we do other health threats? And so opportunities to think about what those research portfolios might look like. Bear with me, I'm gonna turn my camera off to blow my nose. Be right back, sorry. I'll just bear this side, great. That was a first for me, many years of Zoom and haven't had to blow my nose yet, so sorry about that. So this idea that there's opportunities to do research to learn and understand more about the caregiver population. There's also opportunities to take that research and turn it into action. And so just last year, FEMA, in their annual preparedness work, set out the theme of supporting older adults. And we partnered with them to suggest that they need to be thinking about how caregivers of older adults are supported during natural disasters. We worked with partners at Duke to do that grounding research, and then FEMA to develop the toolkit. And the intention here is to say that caregivers are actually the first responders in many situations. They will make the decisions about evacuation. They will have to think about the complexity of if the person they're caring for has challenges with noise or sensory issues or wandering, and what that would mean for shelters or other settings. And so here's a way that we could think about supporting the caregiver population in a space that otherwise they were not seen. And while research is great, there's also opportunities for data. We have so much improvement in AI, data, tech across the board, but the caregiver universe is decades behind. We still do our work across the many organizations that support caregivers independently in silos. And I think some of the best caregiver insights are sitting on people's personal computers in labs and universities across the country. And so we're working to bring that data together to accelerate our knowledge of what has worked and what hasn't. There are many NIH research projects about caregiver supports, and I would be naive to think that all of those had wonderful benefits, but unfortunately we continue to redo some of the same studies and work rather than accelerate what does work. So I think there's opportunities with data and tech to get to those answers faster, especially, as I said, given the magnitude of this population. But perhaps the thing that is most unique in this moment is some work that has been done. We did in partnership with Duke University to understand something that Mrs. Carter knew far before our team or many of in the caregiver ecosystem understood, which is that there's more in common with a caregiver experience than is different. And so we set out to recognize that often, if you go into a caregiver resource center or an area agency on aging or another organization, the first question that you would be asked is, what is the condition or the age of the person you are caring for? And while that's an important question, it became the driving question as to what kind of programs, supports, and services you were offered. And that meant that your caregiver experience was defined by the diagnosis of another person. If we take a moment to think about that, we don't really do that anywhere else in healthcare outside of maternal and child health, where it makes logical sense that someone else's diagnosis, that of the mother, would impact the treatment of the child or vice versa. But yet in caregiving, we bucket caregivers inadvertently or because of funding and research in a way that is not always helpful or supportive. And so, as I said, people in one condition, dementia diagnosis, caregiver, that isn't a single defining factor in describing their experience, but rather you could be at the beginning of an early diagnosis or you could be in the final stages. And your caregiving experience is incredibly different at each of those points. But yet we, in the systems and structures we have in place, would define you in the same bucket. The same is true when we think about broad conditions. The mental health caregiver of someone with a mild depressive disorder as compared to someone with schizophrenia, very different. Their caregiver journey is very different. And that diagnosis or condition may not be the single defining factor of what's going on. There are also people who are, as a colleague of mine describes, serial caregivers. You cared for maybe your spouse, and then you're caring for a brother or sister. Then other family sees that you're good at it, or they rely on you, and you become, over and over, the person in the family who is supporting caregiver needs. That means that you don't need Dementia 101 training when you walk in the door for caregiver support, but perhaps financial or legal supports. Perhaps what you really need is some family counseling or some engagement so that you can get out of this serial caregiver role. But again, that wouldn't be what you got if you said, I'm caring for someone with dementia, and that led to the support you were providing. And I think there's a broad medical element to this, which ignores a couple of scenarios. If you've ever cared for someone who is going through trying to resolve or find a diagnosis, you weren't any less of a caregiver when you were with that person in those doctor's offices. You weren't any less of a caregiver when they were going through those diagnostic tests or you were waiting for that phone call. But our current system would say you're not a caregiver until there's a diagnosis, because then we can provide you a support or a service. if you are supporting someone who has multiple conditions, how do you choose which condition to describe as a caregiver, and therefore which benefits you might be afforded or provided? That is not the single condition, or the single, it's not a single condition that the person has, and yet our system is focused on that single answer. Your employment status, your how long you've been in the role, all of these factors that I mentioned have something to play. There are also conditions for which you may not be comfortable or willing to talk about someone else's diagnosis. Why would I need to explain what my sister is going through in getting supports when it's me who needs the supports? And so this work is really intended to help us move away from that clinical approach. And yet to balance that, if I went to a policymaker and said, every caregiver is going through a unique challenge, there's 105 million different stories, each one has different context, different impacts, different duration. I don't think that conversation would go very well. Regardless of what side of the aisle someone is on, they would say, well, we can't come up with 105 million policies and supports. And yet, when we have conversations that suggest that every caregiver is the same, that every type of support would work the same, things like family medical leave or broad scale approaches, that also wouldn't be sufficient. And so the intent here is to find that balance. In this work, we identified a couple of themes that I think would resonate with many caregiver audiences. That individuals are often trying to balance multiple roles across their time. As I mentioned, from that early diagnosis to maybe the end of life, they're balancing their role as potentially also employed in a paid employment role, other family obligations, and other societal obligations. There's an impact that caregiving has over time, wearing and burden that changes. A person who's been in the role for 10 years has built a number of skills and coping mechanisms, but has also experienced stressors and challenges. Sometimes caregivers and care recipients do not agree on what the optimal next step is or goal. This often comes up around things like placement in a institutional facility, or intention or ability about mobility, or maybe driving privileges would be one. And so when there's that conflict and challenge, that results in more stress on the caregiver. You can't ignore that is sometimes in play. And caregivers are in states of transition at various points in their journey. If you speak to someone on Tuesday, where they are by Friday may be different for a variety of reasons. And so it isn't a single description for that. We also recognize that the community and policy landscape are different. California has a Caregiver Resource Center network, which is unique to a number of other states don't have that type of coordination, and that provides some benefits and services, and other policy environments in states may have an impact on what's available for things, especially like paid leave, tax credit, and allowances for respite being the ability to have a break or an opportunity away from the care recipient, which are often state level. There are family factors. The relationship between the individual who is giving care and the individual who is receiving care can be challenging for a variety of reasons. Past abuses, past relationship challenges, past family issues all come into play in various ways and as part of the caregiver journey. And there's individual impacts, race, ethnicity, and traditional demographics, other availability of resources. All of these factors play in. There's also different types of stressors. We can talk broadly about stress, but when you get down into conversation, you realize and find that these types of stress come from a variety of sources. and for us to broadly offer caregiver stress reduction as if that's a single source and single approach would be naive. I mentioned that caregivers go through phases based on the diagnosis and the condition of the person they're caring for, the medical trajectory, the time in which their caregiver journey started, and a variety of other factors. We recognize that in certain situations, a caregiver may pass away or may not be able to fulfill their caregiver role through the end of life of the person they're caring for. Another individual may need to step in. And so it's not as though we can say that every caregiver is with the person from the start until the end, and we must be respectful of that. And settings change, circumstances change, doctors change, insurance rules change. And so all of those changes have impacts. Caregivers also have goals that may not be all the same. For some, it may be to adjust to what might be considered a new normal. For others, it may be in a prevention mode, reducing the likelihood of a crisis or a challenge. Again, these are all different things that that caregiver is experiencing and that need to be taken into account. And so all of this work leads to these profiles and caregiver experiences. And I pause here because this is work that's been done with Duke, over 10,000 articles reviewed, multiple caregiver focus groups, multiple partners looking at this work across a variety of diseases and conditions to suggest that each of these 10 profiles represents what a caregiver might feel is where they are in that moment. Yes, individuals could feel like they're in multiple, especially if you're caring for multiple people, but that this is a more robust way to describe the caregiver experience. And recognize that people transition between these phases, these profiles at various points, that this is not a linear journey, and that our way of thinking about caregivers would be dramatically changed if this was our approach. And these are, as I've shared these with individuals and groups over the course of the past few months, the one thing that I continue to hear in conversations is that this is a method for individuals to feel seen and for others to understand their journey better. And I'll speak about that in a moment. These profiles are broad. Our work with Duke has more detail to, so what does it mean if I'm in the managing a decline profile and what's going on? I'll share a bit of one of these examples. So this is, I'm a caregiver working on recovery or independence. This provides a bit of an understanding at a high level of what are the types of stress that I'm experiencing and those stressor categories, and what are the caregiver goals that I might be focused on at this point. So we built these details out for each of the 10 profiles through here, with the purpose of being able to have a different conversation with policymakers. I'm not suggesting that we make 105 million different pieces of legislation, and I am not suggesting a single piece of legislation, but rather that when California works on their next master plan on aging, or when the federal government works on their next part of caregiver supports, that we look at those 10 profiles and we look at a piece of legislation and say, is this going to work for caregivers in 8 out of 10 of these experiences? Is it going to work for 1 out of 10? What can we do to get it expanded to support more? What can a healthcare system do to think about talking to a caregiver, the person next to the bed, as a potential patient, and to have a more thoughtful and engaging conversation about them beyond the diagnostic details? Workplaces. Now, if I'm a supervisor and someone comes in and says, I'm caring for this person and this is what's going on, that would be lovely, but that's also a huge expectation that an employee would and could come in with those details. Our approach would be that an employer and an employee could have a conversation based around those profiles, without needing to go into detail and creating stigma challenges or discomfort or privacy issues. And then an HR individual could look at their policies, whether that's the type of paid leave they offer or the type of insurance benefit, and say, are we fully supporting, again, all 10? This policy won't work for a few. What can we do to adjust? I shared a bit about ideas around how this could work for a caregiver resource center, like California's network of those, so that the experience from the moment you walk in the door as a caregiver is grounded in where you are as a caregiver. And then perhaps the one that is most unexpected in some ways is, what is the role for this to be used in community? I believe that one of the challenges we have in supporting caregivers is that we don't have a kind of cultural or social rule book or guideline. When someone has a new diagnosis, maybe, or goes through a surgery, we might set up a meal train, we might reach out or send flowers, but inevitably someone's social and community networks disappear one step at a time once the word caregiver or a few certain conditions are named. What I would encourage you to do when you think about someone in your life who is a caregiver is to try and ask them where they are and try and think about what would be most supportive based on where they are, and to not back away or step away from them, because we don't know what to do. So that's my hope for how we transform thinking about caregiving for the future. But I must be a realist and talk about our current political and policy environment, and what is at play, and what are their opportunities for caregiver support. Far before the most recent election, Mrs. Carter advocated for federal coordination for family caregiver policymaking. Back in 2010, she made this case. It came up briefly when she testified in front of Congress in 2012. And most recently in 2021, she wrote an op-ed making this case, suggesting that while we've made progress in having caregiver supports across various parts of the federal government, we don't yet have a central voice or leadership structure for supporting family caregivers. And why does this, how does this come into play? Well, as you see at the top, only 0.3% of the economic value of caregivers. So estimates from AARP, this yellow, orange circle on the right, shows that the total economic value provided by caregivers, this says $470 billion. Recently, AARP said it's $600 billion that family caregivers provide an economic value, meaning that if family caregivers weren't doing the work that they do, everything from buying groceries and shoveling snow, all the way through to complex medical treatments, IVs and infusions in the home, that creates a $600 billion value. Now, if family caregivers weren't doing the work that they do every day, the individuals who they care for would end up in institutional or structured settings, which would then result in extreme expenses for the federal and state government to undertake. So family caregivers are invaluable. That's not just my bias, that's what this slide shows. And yet, the amount of federal support that we provide to family caregivers is tiny. That very, very small light green circle on this graphic of $1.6 billion, which you see is primarily the VA caregiver support program. The VA does amazing work in the caregiver support space. They have room to improve, like all federal agencies, but have worked consistently over the past decade to provide caregivers with training, to provide caregivers with their own mental health support, to provide caregivers with stipends. And so a bulk of our federal investment is tied to VA caregiver support. What you can see is that family caregivers receive a tiny amount of federal support, and yet if they weren't if they weren't doing their day job of being a family caregiver, the expenses would come back for all of us. And here's what I call my spaghetti chart. Right now in the federal government, caregiver supports are all over the place. Some could be duplicates, perhaps. Some could be incredibly valuable and need to be expanded. You know, maybe some of the work that's happening for caregivers of those with rare conditions should be expanded more broadly because they've been proven through intentional coordination. And despite the fact that there are 100 million family caregivers, there is no one at the assistant secretary, undersecretary level in HHS or anywhere like that that has family caregivers as their exclusive job. And so I think that's just something to sit with. We currently don't have someone who's focused full-time and a leadership role on this population. And I think so that's something we continue to think about and look for. How can we continue to improve the supports by learning across the federal government what's working and what's not? And how can we make sure that family caregivers who, as I said, are tomorrow's patients and who save us all a great deal of money get supports that they need? But that's not the only opportunity. Last year, the Center for Medicare and Medicaid had made some improvements of enabling doctors' offices to bill for caregiver training. So this could be training on things like how to change that bandage or that IV, or it could be training in how to support an individual who has some new behaviors or challenging behaviors. So this is progress, because previously a provider would say, I can't spend time training a caregiver, they're not my patient, and I don't have a way to bill for that. So regulatory change to enable that to happen is progress. And there's also been some great moves in the Medicare fee-for-service program through a program called GUIDE, Guiding an Improved Dementia Experience, which enables a number of supports, as these graphics show, across the board to enable family caregivers to be supported. And I'll show just briefly here that this enables that participants can receive resources to cover the cost of respite. So that could be adult day services or bringing someone into the home or weekend respite. There's a variety of options, but to reimburse for that. To enable hospitals and healthcare systems to create 24/7 caregiver helplines or other infrastructure that might be supportive, and to follow the impacts of caregiving on both the care recipient and the caregiver. That insurers will be looking, with CMS will be looking to see the outcomes. So ideally that caregivers' health isn't declining at rates faster than non-caregivers. But all of this is just getting started as well. So we look forward to seeing what the results are. This is an 8-year pilot. Hard to say a pilot for 8 years, but yes, that's what this is. And so you may hear buzz about it because, again, it creates an opportunity for caregiver supports to be included in our healthcare system instead of kind of invisible and expected. And so I'm going to close with some caregiver pro tips because I suspect, as I said, many of you may be in a caregiver role. But before I get into pro tips, one thing, which is a caregiver non-pro tip, the anti-tip, which is please do not ask a caregiver what you can do to help them. And while that sounds like an intentional and lovely thing, I would just ask you to instead say, I can go to the store for you, or I can bring food over, or I can, and name some things, some options that you can do, so that the caregiver doesn't have to come up with a to-do list and then assign it to individuals because you asked what you can do to help. So just think about that next time you're talking to a caregiver. But for those who are in a role right now, and I guess the second thing I would say on that is when you call a caregiver, ask them how they're doing, and then ask how the person they're caring for is doing. It's a slight switch in how you talk to someone, but it will help put them, give them the chance to answer a question which they are rarely asked. So caregiver pro tips, these are 5. Probably you've heard or seen a version of these before. The first being setting healthy boundaries about what you can't do, won't do, recognizing that boundaries change, and that's okay. The key is to communicate them. And these can be, I have a colleague who wrote up a when to visit and what to expect email that she sends to people so that it makes them feel more comfortable to come visit, but also sets some guidelines so that there's opportunity for visitors for both her and the person she's caring for. Number 2, learn or continue to practice assertive communication. Communication is something we all can always work on. So asking for what you want. This is part of, I think, the other side of that. When somebody says what they can do to help, have an answer ready. What is something that would just make life a little bit easier or a little bit smoother? And what's something I can ask someone for? If they say no, that's okay, but at least I have that answer ready to go. And on the other side, learn and practice the word no, help reduce that stress and burden that I mentioned. Create a care profile. This is especially important as we think about that you as a caregiver may not always be able to be the caregiver or in the caregiver role. I've spoken to caregivers who were in the ER because they had their own health issue, and they're frantically calling and writing down and looking for details for all of the providers, medication and other information, including behavior details if you're caring for someone with dementia or related condition, triggers, challenges, and things like that written down or in some shared. There are many apps and technologies for that. There's also a note on your fridge, but that way, so you can fully figure out if something is going on with your health, you can focus on that. Schedule, because caregiver challenges are many and continue to grow. Every doctor's appointment or diagnostic test leads to more things, so more you can do to schedule. And celebrate your triumphs. I think the idea of a new normal is something that caregivers will speak of and say, perhaps this is not what I would have called success 2 years ago, but this is success for me right now. And engage your family and your community to understand what success looks like for you. And with that, I'm going to stop share sliding, and welcome any questions. Thank you.
Great. Well, thank you very much, Dr. Olsen. I appreciate the feedback on this. It's really quite enlightening. There was one question that I actually had about it. If the Rosalynn Carter Institute depends some on federal funding, and if so, is there some concern about losing support during the new administration with differing philosophies on support for our communities?
Mrs. Carter had a very realistic view on how we received federal support. So we, yes, currently are recipients, but she had worked with us to make sure that we had approaches for engaging with individuals and private funding, so that because she had seen those ebbs and flows many times and reminded us to continue to be thoughtful about that. But I don't think many organizations are as fortunate as we are in having done that work. So I'm worried for the environment as a whole.
Great.
I can understand the things she says.
A couple of hands raised here. If Rachel has a question, you want to go ahead and ask your question.
Thank you. And thank you, Doctor, for the update. It's always really fantastic to hear your presentations. I had a question on the slide that you had talked about silos. And military feels very broad compared to the other ones, which I sort of had a handle on. I was wondering if you could speak to that a little bit. And then the other question I have, and I'll just put it out now, is you talk about family caregivers and the care recipient. But I know in our community, we have a lot of people who, and it's transitional or transactional supports. And I don't know if there's a better term, because that doesn't sound like a good term. And so what you refer to that, because they're not quite family caregivers, but they're definitely very important in terms of supporting our community.
Yeah, I mean, I think there's a question about terms like care partner or care partnership, care dyad, what those can be. And I think we haven't quite figured out the language for that. On the slide about silos, yes, right now the VA military caregivers are in a silo because if you go to many area agencies on aging or other organizations, once you say you're caring for a veteran, you're immediately pushed into the VA system and kind of pushed away from all the other care experiences. But there are caregivers who themselves are veterans. There are caregivers who are caring for someone with a veteran with dementia who might benefit from being with other dementia caregivers in their community or with other caregivers near end of life in their community. And so that's part of our payment system, not looking for the best support for the individual.
Okay, great. Thank you.
Sarah, you have your hand up. Go ahead and unmute yourself.
Thank you. I wanted to say that I really appreciate the caregiver experience profile models. And when I saw those recently in running age-friendly community conversations with carers, which we're doing here locally and run, we use those models to open up the experience of the discussion. It really provided for the caregivers themselves a way to look at all of that, all they do, how to frame that. And so when we ask them the question, what can our communities and our towns and cities do better to support you and to support caregivers, they could come up with far more concrete answers. And usually the answers were, we need help finding the information research issue that they spend so much time doing and negotiating with medical providers. But then also they began to see the benefits of, and these are, a lot of them are very independent people from a generation that doesn't be a burden even on their own children. But the second request was, well, we'd really love to have some discussion groups like we're having here, because hearing the experiences of other caregivers, how different they are, helps me to realize that it takes a lot of different skills and we're not all equipped with all that we need. And there's, in any support group, there is a feeling of not being alone. So the caregiver profile system really changed the kind of conversations we were able to have in community. And so I really appreciate that. And to Rachel's question about naming of caregivers who are like neighborly or friend caregivers, we've been using just primary and secondary in surveys, and I know that's so research and academic based, but by defining primary, secondary, those friends could check the secondary because it really clarified for them that they're the backup, they're the ones doing the odds and ends. And anyway, that's what we had been using. And I also am glad to hear you say in your presentation that it's time to recognize the complexity of identities that individuals have, and that much like in other equity models of disability, for instance, the people who have had a lifetime of inequities, when you add caregiving on top of that, it's far more challenging and complex. So that helps our counties and our states begin to look at resource allocation and add the caregiving element to the other low income and communities of color. So it gives us another way to hopefully in the future see more resources going to these groups. And finally, I'm just grateful that this institute exists. I'm constantly looking at your site to see what you're doing lately, and I feel like you're really enabling us in the age-friendly movement who are trying to add the caregivers and disability to our efforts to support community members. You're giving us the tools to do that. And I just want to thank the Rosalynn Institute.
All right.
Thank you.
All right. Susan, you have your hand up there.
Right.
Go ahead and unmute yourself.
Hi, can you hear me?
Yes, we can.
Okay, I just wanted to I have some very quick little comment, or just wanted to thank you, by the way. Thank you so much. The points that you make throughout your presentation are just really great. You mentioned the physicians and a training. I want to, the Red Cross also, it's not quite, but the Red Cross does, well, you probably are aware of this, I would imagine. I just want to throw out the Red Cross and their trainings. Hospitals, in terms of dementia helpline, 24/7, you mentioned something like that. You probably know this, the Alzheimer's Association has a 24/7 helpline. I'm sure that what you mentioned is a lot more expansive than there isn't that much time.
Yeah.
That I guess I was wondering about, I think Senator Susan Collins has been involved with aging. I'm wondering if there are any there probably isn't time now, but I would have been interested in hearing maybe on the federal side if there's something happening. And the only other comment I just want to make is that I've been a caregiver. My mother died recently, but for a long time. And I found surprisingly that doctors just didn't seem to have a lot of experience. In fact, they were actually nasty to me and my mother. And I was very surprised. And one actually apologized and said, oh, his wife's parents and had dementia. They took care and he had a bad feeling from that or whatever. And I've run into this more than once, including at hospitals. I'm done. Thank you so very much for everything. Oh, is there a way if we want to email you? Just wondering if there's a way that we could contact you. Thank you.
Yes, and I think the slides will be shared with the recording, and we'll get my contact info out, our team's contact info. I will just say UCSF just released a training for physicians and healthcare providers on how to include the caregiver in the health team. So this is great. It provides CEUs for providers, so it's a chance for them to get what they need and for them to think about caregivers. And of course, it's starting out with California, so wonderful.
So she has a new book.
Great. That is perfect. Could you give any websites of links that would be supportive for caregiving options in the chat? Do you have any for us that we can just pass on? Okay.
Our site is great, but I will, I'll add some of those.
Well, I put the Rosalynn Carter's website up on the chat if anybody wants to grab that. So if there's anything else you want to add to that.
If not, just forward me an email. I will, in fact, pass it on. I have a list of these people that are online. That will help, I'm sure.
And
I have one question. We're getting near the end. So just one final for me, and that is med school in particular, they do not teach much on the gerontology side. They're starting to. How are they dealing with caregiving and identifying the needs and the extremes and the stresses? Because as you say, caregiving itself is a stress that can cause illness and more. And they need to identify that. Are they starting to at all?
No, we had a call with the, I guess, association that oversees medical school accreditation, and they said caregiving is not anywhere near the curriculum. And we suggested, when you ask other questions, social determinant or behavioral questions, if caregiving was in that, could that at least open the door for a conversation, which then led to, well, where would you refer a person, and will we get paid for that? Like that's,
Oh,
those kinds of
exactly. Looking
challenging conversations. Yeah. Yeah.
looking ahead, it was I read a comment by a gerontologist in San Francisco in one of her books, and she said, "What's the difference between a large pizza and a general practitioner doctor?" And the answer is a large pizza will feed a family of four. A general care physician, the income from that will not.
Oh,
That was a funny reference that I've remembered.
yeah. Yeah.
Mm.
There are a couple of notes in the chat. California Advocates for Nursing Care Reforms, Family Caregiver Alliance, San Francisco.
Yeah.
Good. These are two great uh, pieces of information. And thank you very much, Dr. Olsen. I've
Yes.
been in and out.
Thank you.
My internet connection is terrible, but I really am looking forward to watching. We are recording this on the central cloud, so it's perfect. And I can't wait to translate it and get it up on our website and listen to it myself in full. Thank you so much for doing this and providing all this information. Our people, being ESCOM, being older, we always are considering caregiving either as a caregiver or what are we going to do to get help when we need it. And you're working in that direction, and I thank you so much. It was a
Well,
pleasure.
thank you.
Thank
Great.
you.
Much.
Best
Thank
of
you.
luck on your new chapter.
Thank you. Thank
All
you.
that news.
Well, with that, we'll say goodbye and good luck dealing
Thank
with
you.
our current administration. I know it's going to be challenging. I think you'll be up to it. Just keep
Thank
priorities
you.
straight, and we're off and running.
All right.
There you go. Thank you.
All right. Thank you.
Bye.
At that, we'll say goodbye.
Thank you.